About myself.
This meeting is being recorded.
Uh-oh, sorry, my computer's acting up a little bit here.
I couldn't see
Okay.
it sign up there.
So
Just want to go and get it out of the ED.
I guess that's what I have to do.
quick reminder, I think there's a few of us that might not have our microphones muted. So if we can mute the microphones and it doesn't pick up the background noise and talking. So just a little bit about myself. So like Joseph said, my name is Dan Longmore. I am a board-certified psychiatric pharmacist, and I've worked here at Provo Canyon Behavioral Hospital for about 8 years, and I absolutely love it. So we've got a fantastic team here, and it's really neat to see the whole team work together, because the medications in psychiatry obviously are just one piece of a much larger puzzle that all comes together to produce the best outcomes for the patients. And that's why this has really become a passion of mine. I've seen that just a little bit more knowledge about medications, understanding how they work, their side effects, the safest way, most effective way to use them, can really have a big impact on how patients end up doing. And so that'll be the focus of this presentation, obviously, today, is the psych meds that we use, how we use them, when we use them. And the way I was hoping to do this, since we have people from such a variety of disciplines and backgrounds, throughout the presentation, I'll stop and just ask if there's any questions, and feel free to put them in the chat. Joseph will let me know on those. Or additionally, like I said, at those pauses, just speak up and we'll discuss whatever you guys, whatever, best suits what you need to know for your practice there. So with that, let me go ahead and share my screen and we will get started here. Okay, is that coming through okay, Joseph? Okay, perfect. Okay, so today for the presentation, our discussion, we'll be talking about first meds that we use in psychosis, and then the meds that we use to treat EPS. And EPS is the movement disorders that the antipsychotics cause. So a lot of the patients that are being treated for psychosis, maybe not a lot, but a number of them end up with these side effects. So we'll talk about how we help mitigate those and identify those. And second one is we'll talk about bipolar disorder as well as other mood disorders, the meds that we use there, medications for depression, for anxiety. And then I wanted to spend just a little bit of time and go into both what alcohol withdrawal syndrome is and how we treat that with medications, because it's different than opioid withdrawal and other things where the medications are actually life-saving. You have to have them for severe alcohol withdrawal syndrome. And then if we have time, we'll move on to long-acting injectables, which are the injections that we use for patients with schizophrenia, bipolar disorder. They've really been game changers for a lot of people and in the industry. And then we'll briefly touch on meds that we use for ADD and ADHD. So the first one here, the meds we use for psychosis. These are the antipsychotics. So they're used to treat schizophrenia, and the rest of the list that I have here, schizoaffective disorder. They're used to treat bipolar mania. And I noted here with psychotic features, but we use these medications to treat bipolar mania, even if there's not psychotic features, if it's a severe mania or they have other issues going on as well. So these are the first ones here. They're the first generation, or they're called the typical antipsychotics, the first ones that came out. Some of these names may ring some bells. We've got chlorpromazine, which is Thorazine, haloperidol, which is Haldol, and then a few others. But really, besides those two, most of these aren't used anymore. The benefits of these we'll hit first here, and then I'll tell you why they're not used quite as much anymore. They're potent. So these have been studied inside and out. We know a lot about them, which sometimes gives them a bad name too, because we know so much about them. We know all their adverse effects. They've been used a long time too. So it's good information that we have. I noted as the second benefit there, sedation, which I've also noted, you'll see on the next slide, as an adverse reaction. So it just depends on the patient there. Just using a made up patient example, if we have Shelly, that's a 16-year-old adolescent track star that is dealing with some body image issues, and she loves to be out, loves to be active, is suicidal, is admitted to our unit with maybe some major depressive disorder with some hallucinations or psychosis, or even bipolar with some psychosis. Giving her a medication that sedates her would be terrible. It would do the opposite of what we're trying to help her with. But on the flip side, if we've got, say, Jake, who gets admitted to a high acuity unit, Jake's bipolar 1, hasn't slept for 7 nights in a row, giving him a medication that sedates him and helps him sleep is essential to his treatment. And so these can be used in certain ways when needed. Oftentimes these are used to help get psychosis or a mania under control, either injection or oral. And then we will cross taper them to a medication that's a newer and a little cleaner. And when I say cleaner, I'm referring to the side effect profile. So as we look here at the adverse effects, one of the primary adverse effects that are problematic with these first generation antipsychotics is the weight gain. And so one thing to point out is some meds and conditions cause weight gain where it's just weight gain, maybe increased appetite or something of that nature. These antipsychotics cause weight gain and they mess up your metabolism pretty bad. So people can end up with high cholesterol, they can end up with diabetes and other issues. So oftentimes, like I said, we move on to a little bit of a cleaner drug once they're better controlled and in a better state of mind. So here's the sedation I mentioned as an adverse effect, could be, either way. Orthostatic hypotension, which is, basically getting dizzy when you stand up, can be problematic for these patients. EPS, which we'll talk about, it stands for extrapyramidal symptoms. And these are the movement disorders, and we'll go into those in a little bit more detail. And then NMS, which is neuroleptic malignant syndrome, very rare, but it's life-threatening. Last case of this I saw, it was actually caught by a combination of a nurse and a care tech. And so it can be caught and brought to the attention of the provider by anybody, therapist, case manager, social worker, anybody. And if this is brought, the earlier the better, because it is rare, but it is life-threatening. And so we need to get them treatment as soon as possible. That happens with the antipsychotics. And then the rest of the slide, I think, is kind of a repeat of what I've said there. So switching gears just a little bit to the newer ones, they're the second generation antipsychotics. And some of these names might look familiar, a little more familiar to some of you. These are also referred to as the atypical antipsychotics. They've over time kind of changed the name just because it isn't very appealing, to tell somebody we're starting them on an atypical antipsychotic medication. But they're the second generation antipsychotic. So we've got Zyprexa, which is olanzapine, brand name Zyprexa. We've got aripiprazole, risperidone, quetiapine, ziprasidone, lorazepam, acenapine, brexpiprazole, cariprazine, and then clozapine. So it's interesting because some drugs, when they're in a drug class, are very, very similar. And although these all treat the same disorders, these drugs in many ways are very different from each other. And we'll run through just a few things that make them different. As a class, as a whole, the adverse effects tend to be weight gain, usually less than those typicals or the first generations. I've noted a couple of the exceptions there. So aripiprazole does not usually cause any weight gain, doesn't usually cause the metabolic disturbances. So going back to our theoretical patient case there of Shelley, our 16-year-old adolescent track star, if she needs something to boost her antidepressant, and other options have been exhausted, or she does have, a bipolar mania, a psychosis, or something of that nature, aripiprazole could be a great potentially a great choice for her. We've got acenapine, ziprasidone, and lorazepam, which also don't cause the weight gain. And then a couple of these new ones, the brexpiprazole, which is Rexulti, and cariprazine, they don't seem to either. They're a little bit newer, a little bit more expensive, hard to get insurance coverage. So those aren't used quite as much as some of the others. Another thing I'll point out there is, I'm not sure you guys have probably seen patients on lorazepam, which is Latuda. Pretty good antipsychotic for like bipolar depression and things like that. Not a lot of evidence for it being used in like acute situations, someone that's floridly psychotic or manic. But we still run into problems with that one in insurance coverage. It's quite expensive. And so we find here in Utah that we have to make sure the patient's insurance will cover lorazepam, because it doesn't do any good to get them stabilized on a medication, even if it's a little bit cleaner, just to have them go to the pharmacy and find out it's $1,400 for a month's supply. And even if it's covered, sometimes with some of these brand name medications, it may be a tier 2 or tier 3 drug. And some of those have a $60 to $200 a month copay. And a lot of these patients don't have that kind of extra money. And so it's important that we balance some of these different factors when deciding what medication to recommend or that a patient should be on. All of them can cause this QT prolongation, which is a little bit of an abnormality with the heart rate. And actually, let me step back just a bit. Not all of them, most of them can, but aripiprazole doesn't, as well as some of the others. Sedation and impaired alertness, and then the EPS and NMS. So just a couple of things when we're on the slide I want to point out. This one here, olanzapine, which brand name Zyprexa there. It's a very useful drug. It's safe in a lot of ways. You can go up quick and high on the dose. So we use it oftentimes to help get patients under control or help them get their psychosis under control. It does tend to cause quite a bit of weight gain. So it causes just as much or more than a lot of the first generation. So weight gain and metabolic disturbances. And so that's one that sometimes, works well, but we want to at least consider cross tapering them to another one that's a bit cleaner. But if it's what works for them, then there are ways to mitigate that weight gain. And lifestyle changes is the number one way. The best way, life interventions with a life coach or something of that nature. And then there's other meds that can be used. I'm sure if you guys have heard of like metformin, which is used for type 2 diabetes. There's showing a lot of promise using that with these antipsychotics to help prevent or even stop weight gain that's occurred with them. And obviously we don't, we want to avoid treating the side effect of one drug with a new drug that brings its own side effects to the table. But once again, if olanzapine or one of these that has some of those side effects is what works for a particular patient, then we need to look at ways to mitigate the side effects there. So as I'm thinking about this, and I'm, I know that we're all from a variety of different backgrounds and disciplines here. If it's a therapist that's seen a patient that's starting on olanzapine, seems to be doing well on olanzapine, helping to intervene early on and give some counsel or direction on how to prevent or mitigate the weight gain, could be life-changing for some of these patients. And if you notice the weight gain starting to occur too, just notifying the provider, helping them know that this is occurring. There's some interventions that they can do there too. So just kind of glancing through the rest of these. Like I said, each of them have kind of their own thing. Quetiapine, which is Seroquel there, it tends to be pretty sedative. And so you'll see that one used when it's used in its low doses. So oftentimes alcohol withdrawal patients or like opioid use disorder patients with those diagnoses will use a small dose of Seroquel, which is the quetiapine there, for sleep. And it's kind of an interesting drug because at its lower doses, it has no antipsychotic effects. So it acts more as an antihistamine, really, but it acts on a couple different receptors. And so you'll see that sometimes used for sleep in small doses for patients with maybe different, like I said, alcohol or opioid use disorder. So.
Dan?
Yeah.
We have a question in the chat. Lisa's
Yeah.
asking if we could explain again briefly EPS and NMS. She missed the explanation. If you could just review that really quick.
Yeah, absolutely. And in fact, I've got a couple slides here just coming up that I'll go into those in a little more detail. So I did kind of glance over those quick. In fact, let me jump there. So the next slide here is EPS. So we'll dig right into it right now. So EPS, its extrapyramidal symptoms are the movement disorder. So I've listed 4 of the most common ones here: akathisia, acute dystonic reactions, Parkinsonism, and then tardive dyskinesia. So these drugs act on the primary receptor. The way they function is a dopamine receptor, a D2 receptor. And that's what helps stop the psychosis and help them with their thought processes and things like that. But just like any drug, these spill over onto other receptors as well. So dopamine receptors in the brain are what manage or control our movement as well. And so these drugs sometimes spill over to those other dopamine receptors and cause these problems. So akathisia, that first one, may be identified really first by a nurse in the setting where we are here in the hospital. It could be a therapist, could be anybody that sees them on a regular basis. especially if a provider is only seeing them once every few weeks or every few months. So what akathisia is it's defined as inner restlessness. And it may seem like a relatively minor deal, but it's not. So there's definitely an increase in suicidality in patients who experience akathisia as a result of these medications. There's also some preliminary data, not a causal relationship established yet, where some of the violent things, actions that are done by patients on these medications may be partially a result of this too, not sure, but it's described as an inner restlessness. So this may be manifest by a patient that's even little things like tapping their toes or inability to sit still, and separated from things like anxiety. So if the patient's always kind of been a little bit restless and had anxiety, toe tapping, that's probably not going to be this. But if we just started them on aripiprazole and the dose has gone up to 10, 15 milligrams, and all of a sudden they're telling you, I can't sit still. I feel like there's this inner itch, and they're moving their legs, something that the provider should know about sooner rather than later, because it can be treated relatively easy. Actually, we have to use another medication, but we use a medication called propranolol or sometimes benztropine, and often, most times, it will resolve the akathisia. The next one here is the acute dystonic reaction. So this is seen oftentimes in hospitals like ours, where we're moving up a little bit quicker on the dose, but it's almost like a really bad muscle cramp, but it's usually in either a muscle or a group of muscles. And so this requires immediate attention, and patients usually end up in the ER if they're not in a hospital like ours when this happens. But it could be the neck kind of stuck back, mouth stuck open, difficulty moving an arm, or arm kind of cocked back and stuck, and that kind of thing. So once again, we can treat those and continue the medication if needed. So just helping the provider and the patient understand that what's going on is helpful there. Parkinsonism, this is where we're basically inducing Parkinson's with the drug, but it's not permanent, it's temporary. It's the medication spilling over there. So you might be manifest as tremors or difficulty walking. Try to reduce the dose or use another medication if that occurs. And then tardive dyskinesia. So this is a pretty tough one. Kind of a sad one. It's usually only manifests and usually only shows up with long-term high dose usage of antipsychotics, particularly those first generations. But it's movements that repetitive movement. Sometimes it's lip smacking or movement of the upper body or the neck or the hands, repetitive movements that they can't stop. And there's really nothing we can do to reverse this. We try to lower the dose or switch medications. Sometimes that'll do it, but usually this is irreversible. I don't know if you guys have maybe seen the commercials. There's some commercials out there for a medication. Brand name is Ingreza. I can't remember I think it's valbenazine, but the generic name. But there's some commercials out there for it now. It helps to treat the symptoms of tardive dyskinesia. It seems to do a pretty good job, but it's extremely expensive, and where it only treats the symptoms and doesn't reverse the condition. We've had challenges getting insurance companies to cover it, finding patients whose insurance will cover it. And when we brought the drug rep in and talked about it, unfortunately, from my understanding, it's nearly $6,000 or so a month without coverage. But there are patient assistance programs and other things out there that can potentially be used. But it's an expensive medication. So up to this point, any other questions on the antipsychotics? We will jump into NMS here in just a second. Any other questions on these that we've covered so far? Okay, we'll keep going then. So here's a couple of the medications we use to treat the EPS. Benztropine is one, and then diphenhydramine is another. Both it can be oral or injection. Outside of the hospital, it's usually oral medication, but they do work well, and they can be life-saving in that they can help these patients continue their antipsychotic, even though it's causing some side effects. And once again, we hate to treat the side effect of one drug with another drug, but you got to do what's best for the patient. And the number one goal here is to treat their psychosis or whatever it is they're going through at the time. Okay, so next one here is NMS, or neuroleptic malignant syndrome. So this is the one I said is rare, but it is life-threatening. I've seen 3 cases in my career, and doesn't happen often, like I said. But there is this acronym here, FARGO, that can be used. It's helpful to remember the symptoms, the signs and symptoms of NMS and when it presents. So the first one, the F, is fever. So a patient with a fever. Obviously, there can be a lot of causes of fever. So what we're looking for is a constellation of these symptoms together. Autonomic instability.
We didn't have your email.
And which is usually high blood pressure. So it can be high blood pressure, low blood pressure, and high heart rate, low heart rate. Tends to go up and down though, but stick on the high side. And then this is an important one, which is muscle rigidity. And so something that may be seen even in a visit at a therapist's office or a social worker working with somebody. If they start to get really stiff muscles, if they have stiff muscles and they got a fever and they're on these meds, we want them to be seen by a provider. Granulocytosis, that's some lab results for blood work, and then orientation changes. So these are acute changes. So confusion is usually what it is. So if we have a patient that all of a sudden is getting confused, doesn't know who they are, where they are, what day it is, or something of that nature, you see an acute change, then we're concerned about this. So as far as treatment goes, there's not an antidote. There's nothing that we can specifically do as far as meds go. We stop the med, and then it's treatment usually in an ICU setting. And they do fluids. They may do a cooling blanket, and then a couple meds, benzodiazepines or bromocriptine, which may or may not help. We don't really know for sure, but they're things that we try. So I guess as an example, we had a patient a number of years ago at a facility I worked at who was on our high acuity unit, and she had schizophrenia and some agitated psychosis. It just was not responding, had been hospitalized multiple times and was not responding to treatment. So in conjunction with a psychiatrist, we ended up having her put on, getting her put on two antipsychotics, both maxed out the dose on both of those, which is uncommon, but trying to help this patient get some sort of a response and quality of life. And she didn't really express what was going on, but we had a nurse go out to help her one evening and realized as she was helping her that her muscles, her arms were really stiff. And as she started to talk to her, she was very stiff. She was on an antibiotic at the time for a fever, which they thought was being caused by a UTI. But long story short is this was NMS setting in pretty quick there. And so the psychiatrist was made aware, immediately sent her to the hospital, and she did recover with some treatment. And once this happens, though, it's tough to start them on an antipsychotic again. We have done it. I've been involved with teams that have done it, but it's a kind of a scary thing. But if you've got a patient with severe psychosis that can't function, it's a tough thing where you got to put a team together and try to decide, is it worth trialing one of these medications again, potentially causing NMS? Once they've had it, we're a little more leery, of course. Or do we leave the patient untreated? So it just kind of depends. But do we cover NMS and EPS? Answer the questions that we had there. Okay, we'll jump on, keep going. Any other questions up to this point? Okay, so let's talk a little bit about bipolar now and some of the other mood disorders there. So manic episode, I'm assuming a number of you on the call here today can probably describe a manic episode much better than I can. But, a manic episode, we usually see people who are feeling grandiose. They're hyperverbal, hypersexual, hyperactive, hyper all of the above. Sometimes there's psychosis associated with that, risk-taking behaviors and those kind of things. They, in some cases, feel like God or that they can control the universe. Oftentimes haven't slept or haven't slept much, maybe a couple hours a night, or like I said, although it wasn't actually his name, Jake, we did have a patient here who showed up and hadn't slept for 7 days straight, was in a pretty severe manic episode. So in these situations, if the mania is considered severe, or if it has psychosis associated with it, then antipsychotics are used. So those medications that we talked about at the beginning there. They're helpful for the psychosis, of course, but they also help put a lid on the mania, and they put a floor on the depression. So they tend to hit all aspects of the bipolar disorder in that sense. These medications, they do have those side effects that we mentioned, so we don't always use them, but they do tend to be very helpful there. The next set of drugs or class of drugs that can be used there are the mood stabilizers. We call them our anti-epileptics, so they're seizure medications. Many of them originally were seizure medications, but they're listed there. So carbamazepine, oxcarbazepine, divalproex, which brand name on that you may have heard is Depakote, lamotrigine, topiramate, and gabapentin. There are some others as well. So these do a pretty good job of helping to control the mood. They do nothing for psychosis though. So if we have a manic patient with psychosis, these won't help with the psychosis. They do help with the mood though, as far as the mania and the depression, with some kind of nuances between each of them there. That Depakote, the divalproex, it tends to be a good one for mania, for patients who are aggressive or angry. It does cause quite a bit of weight gain as well. It can cause some hair loss, and you never want to use it in pregnancy. So if we have a female in childbearing years who plans on becoming pregnant or could become pregnant, kind of want to avoid that. So as far as adverse effects on these mood stabilizers, the anti-epileptics, there's a lot of drug interactions, so they got to be watched pretty closely. And the hepatic dysfunction, which is liver dysfunction, and then blood dyscrasias, which means the either like the white blood cells or the red blood cells, it can kind of mess with the production and handling of those. So you do have to monitor them close. So CBC, CMP, which are some of the labs that are done to monitor it. And then this one I put in red here. So this is part of a presentation that I do for our new nurses. And I always tell them, if you forget everything else from today, this is one of the 3 things not to forget, which is if you've got a patient on lamotrigine, you always want them and you to be keeping your eye out for a rash. So there are a lot of rashes that happen with lamotrigine that are benign, but lamotrigine can cause, I put SGS there, Stevens-Johnson syndrome, which is a life-threatening, nasty, rash, I guess, is a for lack of a better term, but it's really an autoimmune response where patients' skin starts to detach, come off. They end up having to be treated in a burn unit usually. So you want to keep an eye out for rashes developing with lamotrigine. So you got to go real low and slow. We don't use that a lot in our hospital. The reason is you got to go so low and so slow on the dose that it takes 6 weeks just to get to 4 to 6 weeks to get to a therapeutic dose. So we'll adjust doses if patients come in, but starting them here, we don't have 4 to 6 weeks in our facility where we treat, more acute situations to wait till their blood levels get up on that. So now lithium's a good medication. It does a good job of keeping a lid on the mania, putting a floor on the depression, but it does have a number of side effects and some monitoring. So I'm not sure if you guys have had a lot of interaction with patients on lithium. You do have to watch blood levels very close. And I'll point out that when we look at blood levels on a lot of these other drugs, they give us a really general idea of what's going on, if they're in a toxic level or not, but we don't really know exact levels and equaling or translating to therapeutic outcomes. But lithium's very different. Lithium has a very small therapeutic index, which means to get it up to where it works, you're getting close to the toxic blood level too. So you got to watch it really close. So to get them up to where it works, you're kind of bordering on the toxic level as well. And then I noted here that dehydration can cause lithium toxicity. And the reason that happens, and the reason this medication isn't a great choice in some patients, maybe a homeless patient or somebody that can't take care of themselves really well, because if you're taking lithium and you've been seeing your doctor and you've got stable blood levels and you go out and do a bunch of yard work, or we've got a homeless patient exposed to this heat that doesn't have good, a good place to be, you get dehydrated. But when you get dehydrated on lithium, two things happen. Number one is when you're dehydrated, the amount of blood you have, just because the water's gone, the blood level goes down. Everything becomes a little more concentrated in your blood because you lose some of the water out of it. And the second thing that occurs, so that in and of itself, I should say, makes lithium a little more concentrated in the blood. But the second thing that occurs is, as far as your kidneys are concerned, they look at a lithium ion and a sodium ion, salt, as almost the same. And as soon as we get dehydrated, one of the first things our kidneys do is hold on to all the salt, because the water will follow the salt. So what happens is the patients will, on lithium, if they become dehydrated, their kidneys filter out the lithium, but then the body says, hey, we're dehydrated. So as it brings the sodium back in, it brings lithium with it. So you filter out the lithium, but bring it right back into the blood. And so lithium, like I said, it's a good drug, but you do have to watch blood levels pretty close and make sure it's a patient that, can get good follow-up care and will be seeing their doctor and getting the appropriate labs done there. So,
Hey, Dan,
as far as,
we have a question in the chat. Nicole's asking if lithium is safe for people with kidney issues.
So oftentimes, no, it depends on the kidney issue, but generally we're going to avoid lithium if people have kidney issues, because that's a great question. Because some drugs are cleared by the kidney, we get rid of them with the kidney. And so if you have kidney dysfunction or kidney problems, we don't want to use them. And then some drugs may or may not be cleared by the kidney, but they hurt the kidney. They directly assault the kidney. Lithium does both. So lithium can hurt your kidney. Doesn't always, of course, can cause kidney dysfunction. It also is cleared by the kidney. So patients with kidney dysfunction, this is usually not a good choice. Great question. So as far as the depressive side of bipolar goes, it's really the same classes of drugs that we use, the antipsychotics and then those antiepileptics, those anti-seizure medications. And there are some that seem to work better than others for the depressive episode versus the manic episode. And then there's a lot of variability also between providers and psychiatrists. In psych, we, at least not yet, maybe someday, but we can't yet do a blood test and say, okay, Dan's going to respond great to this drug. We're getting closer. Someday, I think we'll be doing genetic tests and others, and we're going to be able to look and say, okay, these are the two antipsychotics that'll work for Dan. But at this point, there's a lot of guessing involved. And so you get some providers that have their favorites, which makes sense, and have had bad experiences with others. And you get other providers that have had kind of a different experience and have their favorites. And it's because there isn't real clear evidence which one is the best, so to speak. And so a lot of trial and error with these medications. I have found in working with patients, both in the hospital and then in my last outpatient job, as well as working with friends and family, that if patients understand when they're starting a medication for whatever it may be, a mental health challenge, that there is a little bit of guessing involved. Sometimes that can be really beneficial. I've talked to a lot of patients who have said, no, that are severely depressed, some of them psychotic, that say, well, I can't do antidepressants. And upon questioning and asking why, it's because they took one and had a bad reaction to it. But oftentimes it's the second or third one that is the one that provides the outcome we're looking for. So if they can understand too that, hey, if you don't have a good response, or you even have a negative response to this one, there's a lot of other options. And at this point, we kind of have to sort through the options, because there's no blood tests like some cardiology situations and other that
This is Crystal.
we can do. Yeah, Crystal.
Hi.
Hi, did you have a question? I guess not. Okay, maybe your microphone just wasn't on mute. So, and so I noted down here that the SSRIs and SNRIs, and those are the antidepressants we'll talk about in just a minute. You guys have probably seen a lot of, like sertraline, paroxetine, fluoxetine, which is the brand names of Zoloft, Paxil, Prozac. Probably seen a lot of those. We generally avoid those in bipolar disorder because they can induce mania. They can be used if we combine them with an antipsychotic, but it still is kind of risky, particularly if the patient tends to get pretty severe mania. So we usually try to avoid those. Seen a number of cases of patients who had some signs, symptoms of mania, but didn't really articulate it well, and went in and got put on an SSRI and went full-blown manic. And that's kind of how they, were first diagnosed with bipolar disorder. So it doesn't cause bipolar disorder, SSRIs and SNRIs, but it can unmask bipolar disorder. So any questions on the meds used for bipolar disorder, depression, or mania before we move on to the next ones? Okay, so these ones here, you guys have probably seen, I'm assuming, quite a few of these, the meds used in depression. This slide, it's kind of busy. We got the SSRIs on the left and the SNRIs on the right. So SSRI is selective serotonin reuptake inhibitor. And then SNRIs are serotonin and norepinephrine reuptake inhibitors. So just a couple points on these. The SSRIs, they affect the serotonin in the brain, which affects mood. The SNRIs affect both serotonin and norepinephrine. So on the outset, that would lead me to believe anyway that SSRIs are good and the SNRIs are better, that they would work better because they have a dual mechanism. That's not the case. So they're generally speaking equally effective, really. We usually start with the SSRIs and then depending on what else the patient's got going on. And then if they don't work, move to SNRIs, not because they're better, but because they're a second option. And so these drugs, like the antipsychotics, do have a lot of nuances and differences between them. One thing that comes out or is a topic of conversation and concern with these drugs oftentimes is weight gain. There's actually a lot of conflicting data out there when you look at the actual studies with these medications as a whole, as far as weight gain. It doesn't appear that, generally speaking, a number of them cause a lot of weight gain, but some do. So Paxil, which is paroxetine, we tend to avoid that one here. It's the most sedative. It can cause a lot of withdrawals when you get off of it. And in addition, paroxetine does tend to cause more weight gain than the others. And then you've got, on the flip side, you've got like a fluoxetine or sertraline, which are the Prozac and Zoloft. Those don't usually tend to cause weight gain. There are individual cases where they do, but I mean, even fluoxetine, for instance, we avoid that in elderly patients that don't eat because it can further suppress their appetite sometimes. But once again, there are individual patients in which this doesn't play out exactly this way. But generally speaking, these don't tend to cause a lot of weight gain, and nothing like the antipsychotics do. When we look at some of the important characteristics, overall, they're well tolerated. But both classes, they take 4 to 6 weeks for their peak effects. And this can be very, very, very important for patients to understand. Sometimes patients even feel something in the first few days, even after one dose. Oftentimes, that's not the same effect they're going to have 4 to 6 weeks down the road. And so it's important for them to understand, hey, this could take a little time. One of the things that can happen there in those first few weeks, especially if we have a patient that has, say, obsessive compulsive disorder or generalized anxiety disorder or something of that nature, there can actually be a little bump, a little increase in anxiety in the first 2 weeks of treatment, and then it comes way back down. I hesitate to tell all patients that because sometimes there's a placebo effect that will kick in there, but certain patients do need to understand that. And, just as a quick example, in my outpatient job, there was an elderly female that got started on Lexapro, escitalopram. And she came in after about a week and explained that. And I said, look, if you don't feel super anxious, you don't have anything, that's really causing you problems, try to push through it for a week or two and then see how it goes from there. And so anyway, long story short, I had actually forgotten about the conversation, but she came in about 2 months later and was just feeling fantastic, gave us all big hugs and was excited that, she felt really good and was grateful to know that sometimes that can happen. You just need to push through it. Obviously, if patients are experiencing panic attacks or severe anxiety, we need to look at something different there. So, and that doesn't happen in many patients, but it does in some. As far as the notable adverse effects here, there is a black box warning. Black box warning is kind of the I don't know, the biggest warning that the FDA can put on a medication, that there is an increased risk of suicide or suicidality in patients. It's primarily adolescents and young adults, but that is something that we need to be aware of. Why that happens, we don't know. It's very rare as well, but it is a possibility. Lots of different theories as to why that occurs. And then a few other things here. Sexual dysfunction is an important one to know, because I've known a number of patients who have stopped these medications cold turkey because they did experience some degree of sexual dysfunction, both male and female. So it's important that they understand that with SSRIs and SNRIs, it's never irreversible. Oftentimes, once you have the condition under a little better control, you can reduce the dose and resolve that side effect, or you can even add bupropion, which is Wellbutrin, that'll sometimes reverse that side effect as well. And then serotonin syndrome, which is rare but life-threatening. And I think I'm going to jump past this slide. These aren't used very much, these TCAs. We oftentimes use them for their side effects. And jump to this one. So I just mentioned the bupropion and the Wellbutrin, which is Wellbutrin. Sometimes it's lumped into the group with SSRIs and SNRIs, but it's not that at all. In fact, there are cases, a lot of cases, where it can worsen anxiety. So if we have a patient that's just presenting with generalized anxiety disorder or something else, Wellbutrin or bupropion is not often the best choice. It's not an SSRI or SNRI. It doesn't cause weight gain, and it doesn't cause the sexual side effects. In fact, oftentimes it can reverse the sexual side effects caused by SSRIs. There is a small seizure risk with these medications, particularly the studies that bore that out were with young adult females with eating disorders, which makes sense because they usually have electrolyte abnormalities, especially if the eating disorder is bulimia. But generally, these don't cause seizures, and it's not a real significant concern with most patients. I will qualify what I said about the anxiety. It can be used to treat anxiety sometimes, but you just have to be careful with this one. It also can worsen anxiety, but it does really well for depression. And then if we need something to boost those, there's antipsychotics and anti-epileptics there.
Dan, we have a couple of questions that came into the chat. So the first one, Luisha is asking if medical or medicinal marijuana is being used for any of these diagnoses. Yeah.
So good question. That's still kind of in the infant stages, I would say, of large placebo-controlled trials, which is where for medications we usually gather our data. So it's being used off-label here and there. There isn't solid evidence published yet to show that it does or doesn't work in certain disorders. So I personally get a little bit concerned about using it for these disorders. Until I see more data. That's just kind of the way I am and the way I work with these meds. It's not to say it does or doesn't work. There obviously are downsides to it as well. It's not a benign drug. So you just have to be careful and do it under a physician's care. So, but as far as on-label approved usage, there's not yet. I do think studies will continue to come out and we'll get a better grip on what concentrations of TCH, all these different things and the different strains, what does what and how we can better treat. But right now it's kind of in its infant stages there.
And then Lisa is asking, do you know anything about recent studies saying depression really isn't related to low serotonin levels?
I do, yeah. So that was one study that was published, I think maybe a few weeks or a month or two ago. And the study presents some interesting information. But the way that they did the study, it doesn't prove causation. So it does show a correlation. It doesn't prove causation, meaning that they did find some correlations with the serotonin levels and depression, and it may be not being related, but definitely didn't prove anything. I think more information is going to come out because these SSRIs that we use, I mean, we see them day in and day out. Very significantly help people with depression. And so don't fully understand where that study sits yet. It is one study though, where they took a whole bunch of all the studies they could get, put them all together and tried to come up with what it may mean. So, well, I think more information will be coming out about that, but but by no means does that mean we stop using SSRIs or SNRIs at all. So I think serotonin plays a role in mood. Exactly how, exactly what the drugs are doing, we just don't fully understand yet. But that's a great question.
And do you have any recommendations for getting off antidepressants?
Yeah. So when you stop an antidepressant, you need to go slow. And I mean, there are people that'll stop these cold turkey and say they don't feel much, but most people do. So you got a couple issues that can arise when you do that. First is the reoccurrence of the depression. So if somebody was very seriously depressed, had severe depression, was suicidal, stopping a cold turkey can potentially even cause rebound depression, make it even worse. So the recurrence of the disorder is one, but the second is what's called serotonin withdrawal syndrome. And this is usually manifest by nausea and vomiting, potentially diarrhea, headaches, and then you can have kind of some nervousness or jitteriness and that kind of thing, and the resurgence of the disease at the same time. But both of those things can be mitigated by tapering off the medication slowly. So if it's outpatient and someone's stopping the medication, we usually recommend that they taper off of it over at a minimum 2 weeks, but usually 4 to 6 weeks, depending on the dose and how severe the disease was. That helps to mitigate. It also helps them get an idea of what the med's doing. So if they're tapering over 4 weeks and at week 2 or week 3, they really start to feel that depression or anxiety come back, they get a better feel for what the med was doing and maybe realize, let's go back up. Or conversely, if at week 2, 3, they're feeling great, then they know that, maybe it's a good time to continue. And you always want to do it under the care of a provider, of course. So. All right. So a couple other meds here. We're going to skip these. Serotonin syndrome. I'm going to be brief on this. Super rare. It actually presents very similarly to NMS, but it's a totally different mechanism. So, but you get some of the muscle stiffness, hyperthermia, like fever and that kind of thing. So good to be aware of that. I'm going to jump through a few of these slides pretty quick here. Anxiety meds, or these are the anxiety disorders. Here's the meds that we use to treat them. The SSRIs and the SNRIs, they are the gold standard for anxiety in general. They can take a while to work, may take up to 6 weeks to work. Visceral and guanfacine are some others that can potentially be used. And then the benzodiazepines. So we'll take just a minute here. So you guys have probably heard and seen a decent amount about these. We've got clonazepam, lorazepam, diazepam, alprazolam. There's temazepam. There's some others as well. So as far as anxiety goes, when they're used in the moment, they're effective. They're very effective, but they're very risky too. Long-term efficacy is a whole different story. So these medications, first off, are usually very sedative. They can be dangerous when they're used in high doses or with opioids. You always got to keep an eye on sedation. So if you're taking one of these, can't be driving while it's in your system, or doing things like that. And couldn't be doing a job like mine if I was, on a benzo, generally speaking anyway. And then tolerance and dependence occurs. So tolerance is when you need more of the same medication, a higher dose to get the effect. Dependence means when you stop it, you get withdrawals. So with benzodiazepines like alcohol, if you stop them cold turkey, you can have life-threatening withdrawals. You can die. That's usually when you've been using higher doses long-term, but they can be very addictive. So we've got tolerance, dependence, and addiction. Addiction is a different thing, which usually has some tolerance and dependence as part of it, but they can be addictive. So here in our hospital, we don't use many of these. We use them to get patients off of these, like use a taper, or to get them off of alcohol, to detox from alcohol. But we don't usually use them. I will just point out, many people use these safely and effectively outpatient, maybe a couple times a week, couple times a month, and that's a really good way to use them. But these, you get a lot of ups and downs. So you may get severe anxiety, take this, feel a lot better, just for it to come back, and up and down. So by the time patients land inpatient, if it's severe enough to be here, we usually don't use these and try to get them on something that's much more stable, as opposed to the ups and downs. And some of our patients too are a little bit higher risk. developing, becoming addicted to these medications or others. Some of them don't have the best home lives or aren't surrounded by the best influences when it comes to drugs and drug usage. So like I said, we usually try to avoid. We actually don't carry alprazolam. It's worth the most on the street, tends to cause the most euphoria, most withdrawal, seizures. So we just don't carry it here. But I will point out, once again, there's a lot of people that use these outpatient safely, and but you do have to be very careful with them too, and you got to come off of them very slowly. So Joseph, I think we're about out of time. So I'm wondering if we just put the brakes on here and do questions, or do you want me to keep going for a minute? What do you think would be best?
That's great. I'm just going to post the code that the listeners will need, and then I'll also post the link to the evaluation. If anyone has any questions, feel free to come forward now, either in the chat or just unmute and ask your question. In the meantime, we're going to use the code MED89, and I just placed that in the chat. That'll be the code that you need when you access this evaluation form, and I've just posted the evaluation link in the chat. Again, if for any reason you're having issues, I know sometimes firewalls at some of our places of business prevent us from accessing Google Docs. If that's the case, please email me and we'll figure out a workaround. Sometimes what I found highly effective is just sending that same link to like my personal Gmail or something like that, and I access it from home or from a different hotspot or something like that, and that will work well as as an alternative. But did anyone have any other questions that they wanted to ask while Danny's still with us? Also, it was previously asked if we could get access to the slides, and yes, Dan will send us his presentation, and I'll make sure that all of the participants receive the slides so that you have those. Let's see. Yeah, we had Lisa who says, yeah, just keep going with the presentation. It looks like Eva's asking, she would like to hear about the ADD meds.
Okay, so let's do that then. I'll jump past the others and we'll go to that. Let me apologize. I just quit sharing my screen, so let me reshare it real quick here. All right, Joseph, that showing up okay now?
Yeah, that looks great.
Okay, so we'll jump clear past this to, and I didn't do a lot on this presentation. I just have this one slide on ADD, ADHD meds. What I'll say briefly here, so we have two main classes, the stimulants and the non-stimulants. As far as just pure efficacy, which ones work the best for ADD, ADHD, is the stimulants. They do tend to provide the best results across the board as a whole. There are individual patients who will respond better to the non-stimulants, but generally speaking, the stimulants do. So some examples here are methylphenidate, which is like Ritalin or Concerta or some of the brand names there. And then you've got the mixture of amphetamine and dextroamphetamine, which is Adderall. Dexmethylphenidate, which is Dexedrine, and then you got a whole bunch of others that are mostly, for the most part, mixes and matches of these. The stimulants, they do a good job. There is some risk associated with these, and some of our patients here, particularly those that are on the high acuity unit, so that are experiencing psychosis, shouldn't be on these medications usually. And the reason I say that is these medications increase dopamine, and dopamine drives psychosis. And so, for instance, patients who abuse these medications, so if we've got somebody, in fact, not long ago, I had to go help on a dial 9 to help restrain a patient who first time with psychosis and was psychotic because he had snorted his Adderall. So he busted up his Adderall, snorted it, and was just floridly psychotic and struggling there. And so whether or not I guess something I should say, make clear here, is these meds in patients who don't have psychosis at normal doses, they don't cause psychosis. It can happen as a really rare side effect, but it's not like, you know, if I take them for my ADHD, that I'm more likely to become psychotic. It doesn't work that way. It does not cause the disease itself, and it's with the normal doses. Yeah, got to make sure that it's a safe environment where they're not going home to somebody, or they've got uncle, aunt, whoever there that's like, oh, I know exactly what to do with the Adderall. You munch it up like this and mix it up and inject it this way, you know, because they can be abused. But an important point is kids who are started on these because they have an actual diagnosis of ADHD or ADD at a young age are not more likely to become addicted to drugs at an older age. In fact, they're less likely to become addicted to drugs if they're treated early on. And so I think that's an important, studies have borne that out over and over again. So that's treating a child that's got ADD, ADHD the right way with these meds does not increase their risk of being addicted to drugs. Doesn't mean these drugs can't be addictive or misused, but it doesn't increase the risk. As far as non-stimulants go, we've got atomoxetine, which is Strattera, and then guanfacine and clonidine. Those are both old blood pressure medications, but they seem to affect the prefrontal cortex and help patients calm down and help patients focus with these diagnoses. The atomoxetine sometimes can help with anxiety potentially too. All three of those tend to be pretty sedative depending on the patient. So that's one of its issues, but can be helpful in certain patients as well. So it's not uncommon to see a patient started on a stimulant that's used in the morning and then maybe like a guanfacine, brand name Intuitive, at night or something of that nature. So as far as the stimulants too, I should point out, you got to monitor weight, not because of weight gain, but because of weight loss. These suppress appetite. And then you got to monitor sleep real closely. I'm thinking more along the lines of kids, because these can make it so they don't sleep as well and don't eat as well. And so you just got to monitor that pretty closely with the kids on this. Any other particular questions, specific questions on the ADHD meds?
Jamila's asking if Medicaid covers Latuda.
Latuda?
Yeah, she wrote Latuda, and maybe it is
Okay.
Latuda. Yeah.
Hey, so that is a great question. I don't know the answer to it for sure because, well, they're inpatient with us. We actually can't bill insurance specifically for meds. We just get the way it works with inpatient psychiatric facilities as insurances just pay a lump sum. But I'll tell you this, I tend to gauge it by what patients come in on. And so, for instance, if I never see a patient coming in on a certain medication in the state of Utah, I'm assuming insurances aren't covering it. I do see some Latuda, which is lurasidone. I don't see a lot of it. So I don't know for sure. Sorry, I wish I had an answer to that, but we don't bill inpatient here for them. So my guess, yeah, I shouldn't say anything. I don't know.
Great. Any other questions before we let Dan go? I'm just gonna place the code and the evaluation link in the chat one more time in case anyone else needs it. I'm also gonna put my email here should anyone have any additional questions or something that you think of, or if you needed to communicate with Dan for any reason, or if you run into any issues with the evaluation, just let me know, all right?
Well, thank you to everybody. It was a pleasure to be here, and I hope some of this information was useful. And I'll send the slides to you, Joseph, and let you distribute them there. If you have any questions about the presentation, when you look at the slides, feel free to email me directly. I'll include that to you, Joseph, and I'm happy to provide any info I can. Thank you.
Thank you, Dan. Yeah, on behalf of everyone, just wanted to thank Dan again for his time and his presentation. I think it was extremely valuable. I've already seen a lot of great feedback in the chat. So I think this was an excellent presentation. Again, if you have any additional questions or anything, please let me know, and we can communicate those to Dan if you have any other questions for him as well. If you'd like, I can hang out for the listeners just a few minutes in case you have any other additional issues, either with the evaluation or anything that you wanted me to communicate to Dan, that's fine as well. Looks like Kyle's happy with the presentation. I got a thumbs up from him, so good. Thanks, Kyle. Thank you, Lisa. Thank you, everyone that participated today. All right, anyone who's still here, do you have any other questions that you wanted to ask? If not, we'll end the presentation and you can watch your email for the certificates that we'll be sending out once you complete the evaluation. Then if you have any questions, please don't hesitate to email me and we'll get those resolved. Yeah, Dan was a great presenter. I'd like to have him again as well. All right, well, thanks for joining us, everyone. We'll talk to you soon.